This is one for James. Can you briefly explain about the differences between ICDs, SICDs and CRTDs, and what decisions are made when the patient is implanted with which one?
Really good question. So there's this, as you've mentioned, there's several types of ICDs out there. So an ICD is an implantable cardiac defibrillator. So that'd be one of these, okay? So this is where patients are at high risk or have suffered a cardiac arrest. So the general patients we see are patients that have had a heart attack and then their heart function's not very good. We know that these patients from the studies and experience are at a higher risk of having a sudden cardiac arrest and requiring defibrillating. So these patients don't have any symptoms sometimes, they exercise well, they can walk around, they don't have any problems. So they just get a standard ICD. A subcutaneous ICD is just a newer technology, and it's just that. It's the one that we can implant on the side, and the lead tunnels up underneath the skin over the heart. At the minute, it's still fairly new technology. It's if you liken it to electric cars, for example, you can choose to have an electric car, but there's not as many out there, and you have to go to the right places to be able to get one. So you couldn't go down to your bog standard garage and say, I'd like an electric car, please.
Mm-hmm.
So at the minute, there's not as many people trained in them. There's not as many centres following up, and they are quite considerably more expensive. So we get a standard ICD for £3,000-4,000, whereas these devices, the sub-Q ICDs, because it's newer technology, it comes with a premium. It's like buying your iPhone. It's more expensive than the older iPhones or the other phones that might be out there. So there's a bit of a price premium on. There are, however, probably patients that do benefit more from having a subcutaneous ICD. We know that potentially the younger patients that don't have any indications to have a normal standard ICD would probably preferentially get a subcutaneous ICD.
Mm-hmm.
And then move on to the CRT defibrillators, the CRTDs, as one person's commented. Now these are cardiac resynchronization therapy defibrillators. Now they're the same sort of patients as the ICD patients, and then so they're at high risk of having a cardiac arrest or they've suffered a cardiac arrest, but these patients have to meet certain criteria. Now I bang on about research because it's really important. We know that we need to select the right patients to do the right thing. The CRT defibrillators are for patients who have heart failure. So these are patients that struggle to exercise, struggle to walk down the street, can't walk upstairs properly, and struggle with everyday daily living. They also have to have a certain other characteristics to be able to get one of these devices. And essentially it's the same can, and it's just an additional lead on top of that, one extra lead. And it helps to resynchronize the heart. Where people with heart failure, their hearts do a kind of a wobble and they don't contract thoroughly because of the damage done to the heart. Maybe in a cardiac, when they've had a heart attack, or if they've got a viral disease that's affected the heart muscle. And by putting two lots of leads in and the other one in the top, we can hopefully synchronize the heart, because the left one is sluggish and delayed and it doesn't contract as it should, and you pace it earlier with the extra lead and it hopefully synchronizes the heart, so it's not going to be doing that again. Mm-hmm. It's very rare, it's only about 5 to 10% of patients that get back to that normal heart function, but if you think about it, someone with a heart function of 30%, if they then go to 35%, it's quite a dramatic increase in the percentage that it's pumping on the heart. And so we find that these patients they still might struggle to walk as far, but they can certainly walk a bit further. Mm-hmm. And so it just depends on if you have heart failure, if you're generally younger, for the subcutaneous ICD, and other issues that may deem it necessary. To be fair, most people get a defibrillator if they don't have any heart failure. If you have heart failure, you'll have the CRT defibrillator.
Okay. Are there any differences between the various manufacturers of these devices? Or are they all going to be doing exactly the same thing, just with different algorithms?
Exactly, you're spot on. It's just like mobile phones. So you know, this one says that it can make a phone call using some sort of clever technology. This one can do the same phone call but with different name to it type thing. They all have very similar algorithms. There are ones that we do have preferential treatment for because they have some slightly different algorithms in them that may benefit certain patients. For example, most of them will have a piezoelectric crystal in it. So if we give you lots of medication to control the heart rate and to stop your fast heart rates, you won't be able to move as much because you feel slow and sluggish and your heart rate's a bit slower, and you can't exercise because your heart rate doesn't come up. These devices will detect that you're moving, and so it will go, oh, his heart rate's not increasing. I need to increase the heart rate, so it paces your heart a little bit quicker until it gets to a certain activity level. If, for example, though you're a cyclist, you're not going to be moving around, so you're not going to be generating that movement, and some people don't move, that won't allow the ICD to increase your heart rate, so you may struggle. So if we know someone's a cyclist, for example, we'll give them a different manufacturer that has a different type of sensor to detect that you're exercising.
Okay.
And so apart from that, they're still pretty much the same. They do the same things. People like different manufacturers at the end of the day.
Okay. I think you've sort of already covered that question. If my ICD failed and I need an external defib shock, would it damage the ICD and my heart muscle, send an electric pulse along the wire and literally cook the heart?
It's very rare nowadays, very rare. I mean, with any sort of new technology, there are obviously certain issues that cause the devices to malfunction. What we say at our centre is, if it does fail, and it's unlikely, it's probably because some of the settings need adjusting if it doesn't work. So when we get phone calls from A&E doctors saying the device hasn't worked, they're in VT, it didn't shock them, it's because of the settings need adjusting, because of maybe the medication, maybe because someone's arrhythmia has changed slightly. And so what we say is, if it's not working and the patient needs a shock, then shock them. We will sort the device out later, and there's no issues from that. The devices are, they're well made. They're made to resist certain things like shocks. The only thing we advise is don't put the pads directly over the can. So, for example, we tend to put a pad up there and a pad down there. So don't put a pad over the device. That will fry it. But don't worry about it. We'll sort it all out later. It's not a problem if we have to change the device, change the leads, and it's unlikely that it will cook your heart, I must be honest. I've never come across someone being cooked by an ICD, maybe just my barbecuing.
No, and as James says, the commonest reason is because we've given tablets to slow that fast heart rate down. And so maybe the setting of the shock is to come at 150 beats per minute, and because of the medicines we're giving, it's going at 140 beats per minute. It doesn't want a shock because it's been told not to. Does that make sense? And then sometimes the guys will reduce that threshold down to maybe 140 or whatever the number is for that patient. So there are, but again, these things are relatively rare.
Yeah, no, definitely.
And it's just a case of finding the right medicines, the right settings, and that sometimes takes a little bit of.
I think maybe it was coming from the angle that I've certainly been told that the ICD isn't 100% guaranteed to work, and maybe if that was a situation that they might get shocked, so they just want to.
I think that's incredibly uncommon.
It's become less common, definitely over the years where I've worked. More research over the recent years has demonstrated that we set devices up slightly differently to how we used to. There used to be a big thing, quick, shock them quickly, get there as quick as possible, get the device to shock them. But nowadays, we know that lots of patients with devices have what we call non-sustained arrhythmias. So they go on for a short period and they self-terminate. And it's quite interesting because before the devices were able to record these, we never knew they were there. But But now we see them more often, and we know that patients get these episodes. We're not so worried about them. And I know we were talking earlier about the time to defibrillation is important. We know that, but the devices take about 8 to 10 seconds to charge up. And if you think about that, if they call for an ambulance to shock someone, that's a few minutes. You know, waiting 8 to 10 seconds is nothing.
When you say charge up, could you just quickly explain what you mean by that?
So the devices all have inside them, they've got the batteries and they've got the circuitry, and they can see that someone's having a fast heart rate. They've gone into cardiac arrest, for example. The devices need to be able to see the signal, and essentially it's looking at how fast your heart rate's going. So if your heart rate's going fast, it has to count up enough signals at a fast heart rate to warrant giving therapy. So it needs to meet certain criteria to avoid shocking people that maybe they're just exercising, and maybe they've just pushed it a bit too hard with their exercise and their heart rate's gone up. And so once it meets that criteria, it then has to charge its capacitor. So it doesn't shock the person straight from the battery. No, exactly. Otherwise, it would fry the battery, fry the circuitry, and just totally deplete the battery. And that's what the main size of these devices are. That's why they're so different in size to the pacemakers, because of the capacitor. If we could get the capacitor technology down, then we can reduce the size of the devices. And so it stores it up into the capacitor, and it sends that electrical current down to the lead, which is inside the heart, and then that shocks between the heart and the can. And so it's like putting 2 paddles and 2 stickers across a heart and shocking across it, and that's what resets the cells within the heart and gets you back to a normal rhythm, hopefully, and 9 times out of 10, if not more, it does. Right, thank you for that. Similar question to the being shocked. I would like to know more about CPR on a person with an ICD or pacemaker. I've been asked by the first aiders at work and just assumed normal chest compressions would be sufficient.
I mean, personally, I think this question is best answered very simply, and I think the answer is yes. I think I would just do absolutely normal chest compressions. Because again, if you think about it, your chest compressions are generally over the mid of the sternum, towards the bottom end of the sternal line by the rib there. And your ICD cam hopefully is up over here. And so again, you're going to be down here in the middle of the chest, and you want to be pushing down as you would be normal CPR. So there's 2 things I would caveat with that. Number one is that CPR is relatively unlikely in patients with ICDs, because you would hope that if it's recognised the arrhythmia, that it would shock the patient relatively quickly. So probably it will charge and shock the patient before that happens. But of course we know that people can also arrest because of non-arrhythmic problems where CPR may be important. But I say I would just absolutely crack on and do whatever is normal, because you may not know this guy's got an ICD.
Yeah, no, definitely. I mean, I know that some patients I've spoke to are worried that they'll break the equipment, so they're worried that they're gonna break the leads. They're worried that the leads are gonna put a hole inside the heart if you do this, and they're also worried that if someone's got a defibrillator, that they're gonna get a shock themselves. And they're all valuable concerns, but they're untrue. So the leads in the heart, they're unlikely to go through the heart. That's very unlikely. You're unlikely to break these leads. You know, I can put on this, and it's
what's that made out of?
The companies protect their secrets, but they're a mixture of polymer plastics and metals and things like that. But they're pretty strong. Can't break that, for example.
And lead fracture is a huge problem if manufacturers have a problem with leads. So when you've got a good design of a lead that's been utilised and the technology works and doesn't fracture and doesn't cause problems, then we want to stick to it. Otherwise, and historically, many years ago, we had a number of problematic leads, and then you have to take them out and change them. So I think they've really upped their game as well with leads, that we don't really see that much in the way of problems.
Definitely. I mean, the companies are investing billions of pounds, billions of dollars, and mainly American companies, to be fair, in research and design, and they're putting the money behind it to make sure that it doesn't fail, because they've had some cases in the past, as Tom said, where there's been issues with the leads breaking, and it's led to some unfortunate events, and so they're pretty hot on it now, and so it's good. And then the last point on that is that if someone does have a defibrillator and you're doing chest compressions, do your normal chest compressions, save their life with chest compressions. We know the research says chest compressions saves lives, but you're not going to get a shock. You have to be touching the metal of the can, or you have to be touching and holding the actual heart, which is unlikely in the settings that everyone's going to be in, to get a shock from the device. So don't worry about it. Do what you need to do. Do good chest compressions, and if there's two of you, alternate between you every minute or so. But just, as Vinnie Jones once said, hard and fast.
Indeed. Can you still do sports as such as rugby and swimming if you're an ICD and no definitive diagnosis?
Brilliant question. Love it. So this came up in the international conference in Chicago in May a few months ago, and a great talk from one of my colleagues over in the States, and looked at all the research behind this, because most people previously have been advised not to exercise. Now there are a certain few patients, and I'm sure Tom can let us know who they are, but they found that in a study that actually doing competitive sports was fine. So things like rugby, things like swimming, running, football, all fine. The devices are well made. They're pretty difficult to break. There's even a case report of someone's life being saved by an ICD when they were shot, and there's a bullet hole in the can, and it's quite interesting and geeky again, I know, so I apologise, but
That had to be in the US.
Yeah, in the US obviously, not in a school, but it was, sports has been found that they're beneficial, their exercise is good for you. There are obviously a few conditions where, if you're sensitive to adrenaline, and Tom, please correct me if that's the case, but if you get have a cardiac arrest because you're adrenaline sensitive, then probably playing sport isn't the best thing. We say for swimming, make sure there's a lifeguard. Let them know that you have a defibrillator. Or go swimming with someone. I wouldn't go swimming in the sea with your defib if there's no one around. I'd play competitive. I'd play football if I wanted to. Rugby, slightly different. You do have to take it in consideration, but you can get the padding nowadays to protect you. I just do the normal things that you would to preserve what's going on, and don't go in for stupid tackles, for example, if you are playing rugby. Most of the damage we find to devices in the past has been at this area here, where the lead connects to the can. So, do everything you can to help minimise that risk there. But on the whole, unless you've been advised otherwise,
that would be because of their underlying condition.
Yeah, exactly. Yeah, and we get lots of questions about cycling. Cycling's fine, again, but just wear a helmet. Be sensible. There's you're not going to hurt yourself too much on a push bike, but you are going to hurt yourself if you fall off a push bike without your helmet. So weigh things up and be a little bit smart about it.
This is similar to the previous person was idiopathic, and would you describe a person who has suffered an idiopathic SCA as one who has an illness or a condition? Is the event classed as a serious heart condition?
Good question. I think it depends who's asking. I can imagine who you're really trying to ask is insurance companies, because they're the ones that are interested in risk, I think. And I guess for you personally as a human being, you want to understand if there's anything wrong. I think that if you've had a cardiac arrest as a result of what is likely to be a channelopathy or something that we don't truly understand, i.e. your heart and your coronary arteries would appear to be normal, but at the same time you've had a VF arrest, then I think it's a serious condition, clearly. I mean, how can it not be a serious condition if you essentially died and then had CPR and were resuscitated? So I think it is a serious condition. I think it's just that we can't understand it well enough, and I think that's our problem rather than anybody else's. We're very good when you've got a blocked artery, when you've got a blocked artery and lots of scar. We understand that, we get that. But I think that we just don't have the tools yet to understand the more finer, discrete problems of a very small minority of patients with a small problem with an ion channel or with other with other more complex things that we just don't understand. And so, in a way, you get a defibrillator because we think that's going to protect you from having further events, but we're doing that not really understanding exactly the mechanism. Who could imagine in 20 years we could give you a drug that makes that ion channel work normally and not give you that risk of cardiac arrest again? But I think we can only practice with the tools we have to diagnose and with the therapies we have to make it better. And so I think that's where we are at the moment, and I'm sure in time that will improve, but we are where we are.
Would you agree that it's generally, if it's a reversible cause, I think makes a bit of a difference?
What do you mean by that, though?
So for example, say maybe someone's been given drugs to cure something else, and if that causes a cardiac arrest, then it's not necessarily an underlying condition.
Yes.
Or serious.
I guess it's certainly not idiopathic if you have a cause.
And it's kind of a reversible.
No, true. So I think the take-home message, I think you need to look very clearly at the issues. We need to have a very critical eye upon the MRI, upon the heart muscle, upon the heart arteries, upon any drugs you may or may not have been on. And then clearly you need to have an expert say, this is idiopathic, I cannot find a cause. And they may or may not want to do genetics, they may or not want to screen family members, etc. Avoid certain drugs which can precipitate it. But I think realistically we tend to put people into a group of patients called idiopathic and then risk stratify, and a lot of these patients will get a device because we don't want it happening again. But it isn't necessarily because we understand it, it's probably because we don't understand it, I'm afraid.
Okay, just going to ask, sort of direct a few questions towards Tom, since James has been talking, holding the line, like say,